Good afternoon or good morning, wherever you're joining from. We will give a couple minutes for everyone to get settled before we get started, since it is a couple minutes before 1. Hi, everyone. Welcome. Um, it is 1 o'clock, so we will get started shortly. I will just give a couple more minutes for everyone to log in and get settled for the webinar. I will also just direct your attention to the slide on the screen. This webinar will be recorded. However, your microphone and your camera will be turned off for the duration of the session. We have also enabled live captions. So if you wish to use those for the session, you can turn those on from the Zoom control panel at the bottom of your screen. Okay, so it is 1 minute past 1, so we will go ahead and get started. Welcome to everyone who is joining. Once again, just to direct your attention to what is on the screen, this webinar will be recorded. However, your microphone and your camera will be turned off for the duration of the session. And if you wish, you can enable live captions for the session. And to do so, you can just access the Zoom control panel at the bottom of your screen. So welcome to today's webinar on moving towards stronger public health, supporting the uptake of core competencies for public health in Canada. My name is Alana Miller. I'm a research coordinator at the National Collaborating Centre for Methods and Tools, and I will be facilitating today's session. I am happy to be joined by Sarah Neal Stramko, who is one of our co-scientific directors here at the NCCMT, and she will be leading us through today's webinar content. Just a couple small housekeeping items before we get started. If you are experiencing any technical issues, first and foremost, I recommend you just log out of Zoom and log back in. 9 times out of 10, that should solve your problem. But if you are experiencing any difficulties, please indicate so in the Q&A. We have decided to disable the chat function for today's webinar, as it can be a little bit difficult to moderate both the chat and the Q&A. So if you are having any problems, please just leave a comment in the Q&A box. We are joined by Krishan Camargo, who is a research assistant here at the NCCMT, and she will do her best to address any of those difficulties you may be experiencing. Throughout the webinar, also feel free to post any questions about the webinar content in the Q&A box, and we will address all of those questions at the end during our dedicated Q&A session. We have also enabled you to upvote on any questions. So if somebody has posed a question you're really interested in or a question you also wanted to ask, please use the upvote function. If there's a lot of questions at the end, we will prioritize those that have the most likes. And lastly, to engage our audience a little bit throughout this session, we will pose some polling questions, both using Slido and Zoom polls. So you will be prompted to answer those throughout the webinar, and we encourage you all to participate. As I have already mentioned, after today, you will be able to access both the webinar recording and the webinar slides from your NCCMT dashboard. I've included a screenshot here of what to look for. These are typically available about a week or so after the session, and we will also post on LinkedIn when they are available. We have no actual or potential conflict of interest in relation to this presentation to declare. So the National Collaborating Centre for Methods and Tools is hosted by McMaster University, which is located in Hamilton, Ontario. And we recognize and acknowledge that we are located on Treaty 3 territory as part of the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So with that, I'm going to ask Krishan to launch our first set of polling questions. These are just some introductory polling questions for us to get to know who our audience is. We're just curious to see if you have visited our website, the NCCMT website before, and if you've used our resources, and if you have, how many times have you done so? Off the bat, I can see that a lot of you have, which is really great to see that you guys are familiar with us and you've used our resources. We do have a couple new faces though here, so that is great, and hopefully you get a good sense of what the NCCMT is about. So the National Collaborating Centers for Public Health is a collection of 6 organizations that were founded in 2007 and are funded by the Public Health Agency of Canada. Our goal is to work together to strengthen public health across Canada. There are 6 different centers, which each have a different focus. So the National Collaborating Center for Indigenous Health is located in Prince George, BC. We have the Center for Environmental Health in Vancouver, the Center for Infectious Diseases in Winnipeg, our center, which is the National Collaborating Center for Methods and Tools, which is located in Hamilton, Ontario. There's the Center for Healthy Public Policy, which is located in Montreal. And then lastly, the Center for Determinants of Health, which can be found in Antigonish, Nova Scotia. Here at the National Collaborating Center for Methods and Tools, or NCCMT, our role is to facilitate and scale evidence-informed decision-making in public health across Canada, and we do so by providing access to high-quality resources, real-world training, and practical mentorship. And we try to respond as best as possible to the ever-evolving needs of the public health workforce here in Canada. Our vision is to advance a stronger public health that is driven by the best available evidence in order to improve the health and well-being of every person living in Canada. Krishan is adding some links into the chat for both the NCCPH website as well as our own. So if you are new to the National Collaborating Centers, I definitely encourage you to check those out. So with that, I will pass it on to our presenter, Sarah Neal-Stramko, to take us through today's webinar content.
Great. Thank you, Alana. Hi, everyone. Welcome. I'm really, really thrilled to be here today to share some of the work that is going on at the National Collaborating Centers for Public Health, and particularly NCCMT, around the new core competencies for public health in Canada. We have over 200 people in the Zoom room joining from across the country right now, which I think really speaks to the importance of this topic for public health in Canada today. So thank you all for being here. We should have lots of time at the end for Q&A. So get your questions queued up, and we should have some time for a good discussion at the end. So we'll go to the next slide. I'm just going to start with a little bit of a background about what are the core competencies and how were these competencies updated? How did we get to where we are today? So core competencies, and the definition on this slide here is from the first release back in 2008. Core competencies are the essential knowledge, skills, and attitudes that are necessary for the practice of public health. So these truly are the building blocks of effective public health practice. And as these are our core competencies, they are independent of the program, topic area, disciplinary background that you come from. These are really across the board core that everybody working in public health should hold after about a minimum of 2 years in the workforce. Go to the next slide, please. And so these really are the baseline requirements of our public health workforce that's needed to fulfill the core functions and aims of public health. And you can see here on the side of the screen, our essential public health functions include health promotion, health surveillance, health protection, population health assessment, disease and injury prevention, and emergency preparedness and response. Next slide, please. So as I mentioned, who are these for? These are for practitioners and frontline providers. They're for consultants and specialists working in public health, supervisors and managers, And these, as I mentioned, are really the minimum expectations for someone who has been working in the field for about 2 years post graduation from a relevant degree or program. And other paraprofessional staff like community health representatives, outreach workers, home visitors, some of these may meet also these competencies as well as part of their regular work, but are not necessarily expected to be competent in all these areas. Okay, we can go to the next slide now, please. So why do we have core competencies? Really, they are used as a tool to unify and strengthen the public health workforce. We can use these as a benchmark to understand where we are and where we want to move. They can be a guide and provide a foundation for professional development, program decisions, and really provide a framework among which public health organizations can operate. Next slide, please. So the first set of Canadian core competencies, or core competencies 1.0, we're calling them, were first initiated back in 2005. And at that time, there was a joint task group on public health, human resources, and they drafted that initial set of competencies. Those were circulated and through a number of consultations with stakeholders across Canada, a second draft was created. Then public health practitioners and government representatives at all levels worked to finalize the core competencies for public health in Canada, release 1.0, and those were released in 2008. And many of you may be familiar with these. They included 7 categories, 36 different competency statements all around public health sciences, assessment and analysis, policy and program planning, implementation and evaluation, partnerships, collaboration and advocacy, diversity and inclusiveness, communication, and leadership. So those were, as I said, released in 2008, and not too long after, there were some critiques of those original sets of competencies, and we'll just go to the next slide, please. Attitudes were not embedded in those competencies. In that original publication of the competencies, it was stated that attitudes were difficult to teach and harder to assess. But there's more evidence that has emerged since then for the rationale for including attitudes and values in competencies, and also validated methods to assess those. So that was an important step forward to make in the update to these. There was also a publication from the National Collaborating Center, what was called National Collaborating Center for Aboriginal Health, now the NCC for Indigenous Health, and they acknowledged that there was really a missing acknowledgement in that first set of competencies about the impact of colonialism on public health and competencies that are specifically relevant for Indigenous contexts. And this all led to the report from Canada's Chief Public Health Officer. CPHA put a statement out in 2002 that stated that the competencies were outdated and that there was really a need to initiate an update. And so a call to action was issued by Dr. Teresa Tam in 2021 in her annual report, A Vision to Transform Canada's Public Health System. And as a start, we need to update our public health competencies to ensure that our workforce has the diversity of skills it needs to meet today's complex public health challenges. And if you think about where we were in 2021, still very much in the midst of the pandemic, and really realizing more than ever before the need for a strong and competent public health workforce. Okay, so we will go to the next slide, please. So how did we go about doing this? So we'll give a little bit of a background just to set the stage for how these competencies were developed and how they inform our work going forward. So go to the next slide, please. So the Public Health Agency of Canada commissioned the National Collaborating Centers for Public Health for 2 distinct projects, distinct but interlinked project. One, to propose structures and processes for the future oversight and governance of the core competencies for public health in Canada. And secondly, to actually go through the process of updating those 2008 competencies by engaging with the Canadian public health community. And so today we'll just focus more on that second piece. For those that are interested, the outcomes of the first project have been published, and we can share those links. So as I mentioned, attitudes and values were one of the things that was noted to be missing in the original set of competencies. values are really understood to be important ways of believing and being that shape action. And a holistic approach for competency statement development integrates values, recognizing that values are really interrelated to knowledge, skills, and actions. So the project team early in the process spent a lot of time working with members of the public health community to discuss their values and how they align with the project. And these are the values that the project team strove to embed within the work. And that includes solidarity, inclusion, love, compassion, kindness, respect, trust, integrity, accountability, courage, justice, and humility. So I think that nicely sets the stage of what we'll see is to come. So this next slide is just a bit of a graphical depiction of the governance of the project that led to the update of the competencies. So if you'll see in the middle, you'll see the steering committee, which consisted of representatives from each of the National Collaborating Centers for Public Health. And this was led by a project team that was housed at the National Collaborating Center for Determinants of Health under the leadership of Dr. Claire Betker, who really spearheaded this project and really made sure everyone was working together for this common goal. So this steering committee had regular interaction and communication with the Public Health Agency of Canada throughout this process, including the Chief Public Health Officer and the Chief Science Officer in each of their offices. On the left side of the screen, you can see members of the Project Advisory Committee, which represented a number of different organizations across Canada that represented different public health interests, occupational groups, so things like Canadian Institute of Public Health Inspectors, Community Health Nurses of Canada, the School Network of Schools of Population and Public Health, Black Health Education Leaders. And then on the right side, you'll see the other public health partners that we worked with. You can go to the next slide, please. So really important for this project was a focus on centering Indigenous health within the project, embedding the health and rights of First Nations, Inuit, and Métis throughout the core competencies. There is a parallel project underway to develop specific categories and statements, starting with an Indigenous writing workshop, and more of that work is ongoing. This focus on Indigenous health was centered through the inclusion of our knowledge keeper, Leslie Spillett, through monthly meetings with the NCCIH, and really working to intentionally align the steps in this process with the tenets of the United Nations Declaration on the Rights of Indigenous Peoples. Next slide, please. So in terms of a bit more details of the process, the first step was really compiling the existing evidence. So looking to the literature on what has been done, consulting experts in the area, getting that background. Then there were steps to build consensus over time with public health practitioners, community partners, government partners. There was regular reporting, integration of the findings throughout each of the engagement processes to update and refine as we went along, and a focus on clear communication in the design format of the competencies. And the next slide just gives you a little bit of our timeline. And this is, a really quick snapshot, but just showing the project kicked off back in June of 2023 with an first Indigenous writing workshop. The narrative and rapid reviews that were conducted to inform the project happened over that summer. The first in-person engagement session occurred in September of 2023. And at that point, there was an initial draft of updated competencies that included 12 categories and 101 competencies. So for those of you who think the updated set is large, you can imagine what 101 competency statements looked like. But as the project was refined, more engagement happens, those drafts were refined in subsequent iterations to try to consolidate those that were similar, remove ones that weren't deemed to be core. And you can see the different drafts that emerged over time. That led to draft 5, which included at the time point of the last in-person engagement. At that point, there were 10 categories and 68 competency statements. And that was the version that was sent out to over 2,000 people who'd signed up for the project mailing list to take part in a Delphi survey that closed in the fall of 2024. And then some subsequent Updates following the results of the Delphi led to our final version of 10 categories, 68 competency statements that was officially launched in September of 2025. Okay, next slide, please. So just to give you a little bit of a snapshot of what the engagement sessions actually looked like, and you can see this picture on the screen was from one of the in-person engagement sessions that was held in Thunder Bay, Ontario. The project team started with looking at the overall categories, then drilled down a little bit further into the statements, talked about the values that underpin each of these statements, and that also included a discussion about use and application, which we'll talk to a lot more today, including what barriers members of the public health community thought they would face in adopting and enacting these competencies. And this was an ongoing sort of process of engagement. Feedback was collected at the end of each session, what was working well, what wasn't working well, so that that could be updated and iterated as time went on. And then lastly, as I mentioned, after those engagement sessions were complete, we launched a modified Delphi survey to test agreement with those competency statements. So we weren't looking for consensus of 100% agreement and pure consensus across, because we knew that was probably an unrealistic goal to make. So a priori, we determined 70% agreement would be considered appropriate to move forward with those statements. So in fall of 2024, the Delphi survey was sent to a mailing list and some additional snowball sampling techniques were used. The team had a goal to collect 300 responses to the Delphi with representation across the country and in various roles, etc. But we actually had 555 completed surveys, which was great to see. And while our a priori, we had planned to have subsequent, as is common in a Delphi survey, typically there's a first round, you were fine, you send it again. There's typically 2 to 3 rounds in the Delphi survey before you get to your set agreement. But after the first round, we actually had overall 86% agreement for statements, and as a whole and across each of the individual statements, agreement ranged from as low as 71% up to 95% agreement across those over 500 people who completed the survey. So this was really reassuring to the project team, and I think really speaks to the quality and integrity of the engagement process. That, you know, this was not something that was developed by academics or researchers or just the NCCs, that these statements were really grounded in what we heard from the public health community, which I think was reflected in this really high agreement. So after one round, we were able to wrap up the project earlier than planned, which almost never happens, and we were able to move forward. Next slide, please. Okay, so now we'll present the competencies themselves. So we'll go to the next slide. So here are our 10 competencies, which include 64 different statements. Categories include public health sciences, assessment and analysis, policy development and analysis, program planning, implementation and evaluation, public health advocacy, communication, partnerships and collaboration, leadership, health equity and social justice, and ethical and reflective practice. And throughout these, there is a strong focus on equity, social justice, and reflective practice throughout all of the domains. Go to the next slide, please. So this, again, these are the same categories as you just saw, but just to highlight what the real key differences are from the first release. So those that are in red were originally domains that were grouped together. So policy development and analysis and program planning, implementation and evaluation were originally one category, as was public health advocacy and partnerships and collaboration. So those have been separated out into their own distinct categories. And we also have 2 new categories, health equity and social justice, and ethical and reflective practice. Go to the next slide. So I noticed that Krishan has put in the chat a direct link to the new competencies. So if you haven't had a chance to look at them already, I would encourage you to take the time and read through those. But just to give a little bit of a snapshot for those who haven't had a chance to do that yet as to what these include. So this is the category of partnerships and collaboration. There's 4 statements here. This category really focuses on competencies related to developing and maintaining good relationships and partners and community mobilization. So we can see here 7.1 is to seek out, establish, and maintain trusting, respectful, and reciprocal relationships with individuals, communities, and organizations, including organizations in other sectors. 7.2 is being partner with community organizations, leaders, and other sectors to promote population health and well-being, address public health issues, and advance health equity. 7.3 asks us to identify the possibilities and limitations of collaborations and partnerships. And 7.4, to use participatory approaches to mobilize individuals and communities, promote self-determination, and share power and decision-making. So this gives a bit of a snapshot of kind of the flavor of the new competencies and how these may be a little bit different from what we saw in Release 1.0. Go to the next slide, please. And here's just another example from ethical and reflective practice. And I won't take the time to read each of these, but this really focuses on ongoing learning, recognizing privilege, and integrating that into day-to-day practice. Next slide, please. So now that we have these competencies, very important, essential first step in being able to move forward with continuing to promote the public health workforce across Canada. But how do we go about using these? And that's what we'll spend the rest of our time together here discussing. So as I mentioned, as part of the project's initiation was a series of rapid reviews and a look to the literature to see what has been done in the past and what can we learn from implementation of other core competencies in other jurisdictions to inform our work moving forward. So at the NCCMT, we completed a rapid review to ask what is known about the implementation and evaluation of core competencies for public health, and what barriers or facilitators for implementation have been found. And so within the literature that's been published, there is 2 kind of streams of work that it focused on. The first being the use of competencies in education and in training. So in the realm of education, competencies have been used to develop curricula, for course design, for evaluation, student evaluation, and there is some evidence of effectiveness for a competency-based approach to enhance student learning. Findings were that faculty of different schools of public health, schools of nursing, are generally supportive of using competencies as a frame for the curriculum. And from the student perspective, there were positive evaluations of courses that were designed and built around competencies. The overall effectiveness of educational programs to increase competencies compared to those that are not centered around competencies has really only been tested in a small number of studies. The evidence does look promising, but there is quite limited literature right there. All the studies that we reviewed found that student self-assessed competency tended to increase after specific competency-focused educational interventions, but really the certainty of that evidence is quite low, just given the limited number of studies. In terms of barriers and facilitators, what we found, and it's probably not surprising to those of you who work in teaching and education in public health, is really the number of competing priorities. We wanting to integrate the core competencies into educational contexts. There can be some limitations in terms of the time available to do so, and other requirements that are needed within programs. For example, in schools of nursing, there's accreditation. You need to cover a whole host of different topics in a typical undergraduate nursing curricula. So those competing priorities were really found to be an important barrier. Difficulties in the complexity of what public health looks like, and the various different roles in public health and how that can be properly integrated into course curriculum. And then just really some questions from or uncertainty from the experiences of educators and instructors and programs themselves around whether or not the investment was worthwhile. Does this actually link to improved employment outcomes for students? So a little bit of concern around that. Is it worth investing the time in this competency-based education if we're not sure whether that translates to better future employment outcomes for our students? We'll go to the next slide, please. So then there was also some literature that we found that focused and reported really on use of competencies in the workforce. So we found that in workforce settings that competencies had been used for workforce training, for performance assessment, in guiding the creation of job descriptions, and also in discipline-specific competencies. So core competencies were used and leveraged to then build specific competencies for public health nursing, for public health inspectors, and other discipline-specific areas. We also found that there is some evidence that workforce training that is grounded in core competencies was able to increase the capacity of the public health workforce. But just like the data in the education sector, there is very limited data that has been published. I'm sure there's lots more work that's been done in this area, but that kind of work is typically not published in the academic or even gray literature, so it was hard to find. What we did find to be real challenges and barriers when integrating competencies into workforce settings was a need for some type of established indicators or tools to measure progress along those competencies, and the lack of established indicators in this area really hampered sort of integration of those competencies into the workplace, that there were a number of organizational factors that were at play. Again, competing priorities, questions of the level of prioritization of that within different organizations was found to be a big barrier. And then the resources required. So there was a need for support from leadership in terms of allocating staff time for continued professional development in this area, resources to either pay for external training or to establish training materials themselves. So that has what's been reported so far. Go to the next slide, please. So all this today in terms of knowledge gaps from what we know from the literature, there really has been very limited published evidence for the role of core competencies in public health across disciplines. Of the studies that did monitor sort of change over time in response to the use of competencies, many of them relied on competency self-assessment tools. And we know that there is some bias in using a self-assessment as an evaluation metric. What we don't know is really what the linkage is between increase in knowledge and skills and what impacts that have on ultimate practice and then practice-related outcomes and ultimately changes to population health-related outcomes. So while we really believe that by increasing knowledge and skills of the public health workforce, we'll only be doing our jobs better, which will result in improved health outcomes for our population, there's a lack of evidence that actually documents that. So which could be a really important tool for advocating for strong use of competencies in practice. A lot of the work that's been done in the area of core competencies has focused on dissemination of the competencies, so sharing the competencies more broadly, making sure everyone is aware, generating awareness of them, but less on focused implementation and on-the-ground support for utilizing the competencies in practice. And so what we still don't really know is what tools are truly most helpful and most essential to ensure that we can build a skilled, competent, and confident public health workforce. Next slide, please. So next, I'll talk a little bit about a study that we did as part of sort of embedded within the engagement process to learn about the potential use barriers and implementation supports needed for the core competencies for public health in Canada release 2.0. Go to the next slide, please. Okay, so this, we saw a little bit of this information on the timeline slide that I presented earlier, but we collected, just to give you a sense of where we collected this data from. So there were 58 different engagement sessions over the course of the Competency Update project, which included over 2,300 attendees from coast to coast to coast. Across all of those sessions, we collected over 2,200 handwritten notes and comments, whether that be through questions that were asked in online engagement sessions through Slido or other different online tools, sticky notes and Post-its that were stuck on chart paper, as in the picture that you saw earlier in the slide. So we had a lot of really rich data that was collected. And you can see on the right-hand side of the screen here that across these sessions, 3 were Indigenous specific sessions. There were 2 sessions for Black health education leaders. There were 12 regional in-person sessions across 7 provinces and 3 territories. And then 2 additional virtual were held for New Brunswick and Newfoundland. There were 5 general sessions that welcomed all comers, all public health practitioners, 3 that were held in English and 2 that were held in French. And then there was 1 bilingual session that was held for members of the Public Health Agency of Canada and Indigenous Services Canada. So we had all of those, over 2,000, pieces of data to analyze, as well as some open-ended responses from the over 500 people that responded to the Delphi survey. The next slide, please. So we used a qualitative descriptive approach to our data analysis. All of the data from the engagement sessions and the Delphi were entered into NVivo. They were double coded using conventional content analysis, and key themes were analyzed by the research questions. Go to the next slide, please. So just to give you a snapshot of what the participants looked like that contributed data to this study, they were distributed across all provinces and territories. About 35% reported working in, or that their work focused on public health in urban areas, just under 10% in rural and remote areas, 5% in northern, and 41% reported that their work spanned both urban, rural, remote, some or all of the above. About 38% worked in either local, municipal, or regional organizations. 36 worked for provincial territorial organizations, and about 16 worked at the federal or pan-Canadian level. We had a real range of experiences in terms of years of working in public health. About 13% were new to the public health workforce with less than 2 years of experience, and about just over 20% had worked in public health for over 20 years. So we had a really great snapshot of a breadth of experiences. About 44% worked for health authorities or public health units, 21% worked in government, about 12% worked in academic or research centers, and then there was a smattering of other, organizations represented in this data as well. Okay, you can go to the next slide, please. So in terms of the anticipated usage, so keeping in mind this was data that was collected during the update process. So as people were hearing about the new competencies, providing input, engaging with that work, reflecting on them, what they really anticipated using these competencies for fell under 4 types of categories. The first being advocacy and communication, both internal and external. So what people really talked about is being able to use these refreshed competencies as a way to advocate for the broad role that public health can play in our broader health system and in other systems and in our communities. So being able to talk to other organizations to really make it clear what public health can and should be doing, and to use it as an internal advocacy tool as well to advocate for more funding, for additional partnerships, those types of things. The core competencies could be used for organizational and system level planning to help understand, what are the skills that we need to have within our workforce and how to allocate resources appropriately to fulfill those. They can be used to guide education and training. So education meaning in our post-secondary education, so not only the graduate level in terms of Masters of Public Health programs, but also at the undergraduate level from all of the other places that the public health workforce comes from. And that the competencies would be used in human resources. So things like self-assessment, ongoing performance management, recruitment, onboarding folks to public health for determining promotion, those types of things. And on the next slide, you'll see a nice quote that came from one of our engagement sessions that kind of exemplifies the use as an advocacy tool. So it's really helpful to say that these concepts are public health competencies when managers or supervisors don't always support the work for things like anti-racism. So this could be used as a tool to say these are the core competencies for public health. We should be acting upon these in our day-to-day work. So next we looked at barriers to use. So what are the things that are going to make it difficult for people working in public health to adopt these competencies. So we heard a lot about the ability within people's individual roles to enact the breadth of competencies that are displayed here. But sometimes there were scenarios in which they wanted to be able to do things like advocacy, but that wasn't seen as necessarily being allowed, or they weren't empowered to do that within their role. Another thing that came through strongly was the need for buy-in from all levels. So support from frontline workers, from frontline public health practitioners to be able to do the work that they need to exemplify these competencies, from managers and supervisors, and from higher level leadership to allocate the appropriate resources for these. But there was going to be a need for support for professional development. So some of the competency statements, maybe those that were similar from the first release, or other things that were seen as more bread and butter. People reported that those were well underhand, but that some of the competencies really would need professional development for many of their staff to sort of be brought up to speed. And then the last barrier that was reported was really the difference in structure of public health across Canada, within different provinces, within different organizations, and that it could be quite complex for to think about, an implementation plan to support uptake in all of those very different areas. And if we go to the next slide, this is one quote that exemplifies that last point. So this person said, "These all make sense in terms of public health, and depending on the position, may require higher aptitude in one more than the other. So, for example, understanding concepts and research methods is generally important to public health, but more so, especially in positions relating to epidemiology or data analysis. So, again, if these are our core competencies, we all accept that, but how those are exemplified might look very different in different roles, and that it would be a challenge to think about how we could support uptake of those in roles that look very different." So finally, we asked people what implementation supports they would need to help overcome these barriers. And by and large, the thing that came through loudest and clearest was need for training and education. So many folks felt that within their own organizations that there was limited capacity for already developed in-house training and education tools. And so that would need to be a real focus moving forward. There was also a call for some really sort of practical, tangible tools, things like case studies to showcase what these look like, tiered examples. So building on what the quote on the last slide said, what does this look like for someone who is an epidemiologist compared to someone who is a public health nurse? What do these look like? Possibly some templates for performance assessment that could be used by managers and supervisors, as well as job descriptions. So examples of how we could actually integrate these into the job descriptions that we have. And lastly, supportive leadership came through. While not sort of a tangible thing, that really for these competencies to be used and used to the optimal extent, there would really need to be support from leaders to make the time and space to be able to start utilizing these. So next, I'll share a little bit of the work that's underway within the NCCs that we're aware of that can help to address some of these things, and that hopefully some of you can start using in your own roles and organizations to help to adopt these competencies. So the first tool that's sort of available is the glossary of terms. So this is drafted based on a scan of existing documents from other competency frameworks and the glossary of terms that was included in the 2008 release 1.0. These were terms that were gathered through the engagement sessions and the Delphi comments, and these terms are available in both English and French, and they are right within the document that is in the link that Christian shared earlier on the core competencies. So at the end of that, you can see the glossary of terms, and that just helped to operationalize some of the things, how we mean them within the competencies themselves. So I encourage you to take a look at those if you haven't already. Go to the next slide. So the next tool that we've developed here at the NCCMT is what we're calling our Core Competency Mapping Tool. And the QR code here on the screen will take you directly to that tool on our website. And Christiane has just popped the link into the chat as well, if that's easier. So this through a comprehensive review of resources from across our 6 NCCs. There was 472 that we reviewed and mapped to each of one of the 64 competency statements. And we chose somewhere between 3 to 5 per competency resources that were available through the NCCs that really support learning around each of the competency statement. So to be included, they had to be aligned with the focus of the competency as well as the action statement. So for example, understanding versus doing. So this is very much our first pass. It is not meant to be an exhaustive list of all of the resources that may help you to build competency in a specific area, but really identify the resources that are most likely to be helpful for you as you start on your learning journey. Across the 64 different competency statements, we were really pleased to see that we had good coverage across most of them. But there are some that we, have there's more robust tools and others that are a little bit leaner. So this is very much a work in progress, and we welcome any and all feedback that you may have on ways that we can improve this tool, make it easier to use, any resources you think that you know of from outside the NCCs that would be helpful to include. We are definitely all ears and keen to hear that. So if you go to the next slide, please. This just gives you a little bit of a picture of what the tool actually looks like. So you can see on the left-hand side, you'll see each of the 10 different categories. And if you click on the down arrow to show, you'll see each of the individual statements. You can hover over the statement itself to see what the statement actually is. And then if you select the checkboxes beside the specific statements, you'll see those pop up on the right-hand side of your screen, and that will link out to the specific tools that we have identified as being relevant to that particular competency. Go to the next slide, please. So we hope that this is an important and helpful resource to support you on your learning journey. Each of the resources contributes to one competency, but as I mentioned, this is not comprehensive, and we have more to do in this area. This was a preliminary scan, but we're certainly looking for ways to continue to enhance this tool and make it a bit of a repository, places that you can go, whether you're working with students or with other staff, or using it for your own professional development to help you utilize and adopt some of these competencies in your practice. Okay, next slide, please. So also underway, led by Dr. Emily Belita, who is a colleague of ours in the School of Nursing here at McMaster, and a few members of the different NCCs are part of this project team, is the development of a Canadian survey, the Canadian version of the PH Wins survey. And the goal of this project is to establish a standardized public health workforce indicator set and develop a data collection system to support the ongoing assessment of the public health workforce in Canada. And this project is funded by the Canadian Institutes of Health Research through a project grant to Dr. Belita. Go to the next slide, please. So right now, the project is in phase 1 in this development of the Canadian survey. So the first step that was undertaken, there were 7 focus groups were completed with 36 different public health decision makers with representation from each province and territory. And revisions are currently being conducted to the original PHWIN survey, which is a US-based survey and has been collecting data in the US for a number of years now. So the working group is integrating feedback from the focus group findings, specifically around core competency assessment, and that will be supported by representatives from the NCCs. Then we'll move into phase B, which is upcoming this summer, where we'll be conducting some content validation with a panel of experts in both English and French, and pilot testing the survey in early summer. As if all goes to plan, which I'm sure it will, we'll be moving into dissemination of the survey in late summer or early fall 2026. Go to the next slide, please. So this just gives a little bit of an example of the items that we're looking that are being revised from the original US-based PHWin survey to update to the Canadian context. So questions around the workplace environment, including things about burnout and intention to leave, skipping down workplace infrastructure. So thinking about organizational commitments to health equity, collecting data around work situation, um, characterizing the workforce demographics of the public health workforce, and importantly, highlighted in the middle, a training needs assessment. So updating the core, they have a core competency self-assessment tool based on the US core competencies, but we'll be looking to update that. And then that tool will be available to others, not just within the survey, but beyond. So I just, at the bottom of the slide here, you'll see contact information for Emily. If you are at all interested in being part of the content validation or pilot testing phase of this work, please reach out to her. I know that she's been doing a lot of amazing work in engaging and collaborating with public health decision makers across the country. And I think the more eyes we can get on this, the better. Go to the next slide, please. At the NCCDH, they are also working on some practice examples to really bring those competencies to life. And so that was one of the pieces that we heard about in the engagement, that it would be really great to see examples of those competencies in action across different roles, across different disciplines, to really exemplify how these apply in the public health workforce. So we have been through a few sessions at the Fall Sci-Fi Conference at CPHA last year. We've been collecting and sort of crowdsourcing some examples of these competencies in action, and so more to come on that. And we are still working to spread the word. We will be at CPHA in Montreal next week, sharing some more details about the competencies. Members of our team are attending the Community Health Nurses of Canada conference in Vancouver in May. And so we've been conducting a number of presentations with provincial public health associations and different organizations. So if you do know of an organization or group that you think would like to hear more about the competencies, or might like to have conversations about support to develop those competencies, please reach out to us. And another upcoming project that we have through some funding also from the Canadian Institutes of Health Research, we are going to be launching a new study starting in the fall, where we're testing the impact of the Project ECHO model for public health. So ECHO is short for the Extension for Community Healthcare Outcomes Model. It's an evidence-based, scalable solution to enhance capacity and build competence in diverse fields. And it's been tested and shown to be effective in a number of different more clinical applications, but has also been tested in public health. And we're looking to develop a Project ECHO model for public health in Canada. So the aim are to evaluate changes. We'll look to see whether this results in changes in individual knowledge, attitudes, and competence, as well as organizational practices related to the core competencies. And we'll be conducting a mixed method process evaluation to understand the barriers and facilitators to competency adoption. So we are very fortunate to have to be partnering with 7 different organizations across Canada to start to deliver this model. And I see a few of those names on the call today. But if there's anyone else that's interested in hearing more about this work or possibly being a part of it, please reach out. So as we come to the end, this is a slide that we co-developed across our NCCs for really at our last collective in-person meeting in Ottawa, which was in the fall of 2024, where we really tried to envision, what do we vision, what do we foresee as a future of public health in Canada, utilizing these competencies. And so our vision really is for a competent, sufficient, and engaged public health workforce that has strong relationships with diverse communities and people, that the public health workforce is agile and prepared for response to whatever things may emerge, and that it's contributing to a healthier and equitable Canada. And we really hope that these competencies can help move us along towards this vision. So, lastly, we'd really like to hear from you. What other supports do you feel that you need to adopt these competencies for yourself or for your organization? So, we would welcome you to join our Slido. So, you can use the QR code if you have your phone handy and you want to join on your phone, or you can enter into a web browser, slido.com, and enter number 9259824. And we would love to hear from you. And I think if we go to the next slide, we can start to see any of the responses that are coming in. So I see a few people starting to type. Okay, support for upper management. Thank you for that. Yes, and that was definitely something that came up in our engagement sessions as well. Assessment tools, wonderful. Emily Belita will be very happy to hear that. And so we'll be looking to share that as soon as it's available. Some key messages. Training options to match the competencies, training for senior leadership, discussion prompts for team meeting. Okay. Alignment with public health standards. Yeah, that's an important piece. Training, policy changes related to Indigenous health. So Slido is sort of summarizing some things for me. Competency is coming up a lot, not surprisingly, but training is coming up again and again. Recording of this session. We definitely will have a recording to share. So I think there's some information in the chat about that, but that will be available. Yeah, assessment tools again. And I see a heart beside assessment tools, so that's great. Examples for different disciplines. Wonderful. So we'll keep that open as it looks like there's still some people typing. So thank you very much for sharing these ideas with us. It's really helpful for us as we're planning our next steps in ways that we want to support competency development across the NCCs to really hear on the ground what it is that people are needing to help them in this work. So thank you. Thank you very much for that. And I'll just add that if there's anything that comes to mind after the webinar is over today, please reach out to us at any time. Great. Okay, well now onto the Q&A.
Okay, thank you, Sarah, for walking us through the new core competencies and hopefully inspiring everyone on the call to work to adopt these into their practice. We have quite a few questions already in the Q&A, which is great to see. Please, we still have close to half an hour, so continue to add those questions into the Q&A and we'll try to get through as many as possible. And just a reminder, please upvote questions. If there's one you really want an answer to, we will prioritize those. But let's get started. So I have one question here, Sarah. It says, seems many of the public health core competencies are complementary across many other disciplines outside of public health. How can we further the conversation that public health is everywhere and reduce siloing of the work?
Mm. Yes, thank you. Thank you for that. And I think that idea of intersectoral collaboration is really important and comes through the competencies themselves as being one of those pieces of as a public health professional being able to interact and share that with other disciplines and in other sectors. So, and I think interestingly, I think said in a different way, this is sort of what came through in our engagement around using these competencies as that advocacy tool, both internal to public health and external in other areas. How do we further that conversation? I don't know that I have a great answer to that. I think it's sharing some of this as broadly as we can, particularly in some of those sectors or disciplines that bump up with public health more frequently. So, one example is we presented to one of the federal nursing tables. So, of course, many of those nurses may work in public health, but many of them worked in acute care and primary care, and we heard the same thing from them as well. Like that, some of this is really core to what we need to do. In other nursing roles as well. So I think there is a lot of complementariness there, and certainly very, very keen to support any of those conversations. If there's certain organizations at tables that would be particularly helpful for sharing that, then we're all ears. But I think there is probably some more work or need for some type of tools to help sort of facilitate that conversation a little bit more.
Okay, another question here. Do you have any advice for engaging organizational leaders who feel that some of the focus of the competencies, particularly on social justice, is out of the scope of work for public health or a public health authority?
Mm-hmm. Yeah, thank you for that question. So I guess one of the things that I would really, emphasize in those conversations is a little bit about how the competencies really were developed and the extensive engagement process that occurred across the country, across disciplines, from frontline health to medical officers of health, provincial medical officers of health, that these really were sort of a ground up sort of inductive process to develop these core competencies that really reflect. I think we can, safely and confidently say that they really reflect um, the opinions and experiences and values of the public health workforce across the country. So this wasn't, an academic exercise, or, a small group of people sitting around the table, you know, thinking about these aspects. There was really broad representation. We think probably the most extensive consultation that's happened with the public health workforce since the original competencies were released, if not ever. Um, but I think it really gives a lot of understanding that process and how robust that was and how broad that engagement was. I think really showcases, and the really high agreement we had in the very first round of the Delphi really shows that this is sort of a pulse check of what public health across Canada looks like. It isn't just the opinion of a few people, and I think that maybe some of that might help strengthen the justification that this really is the core to public health in Canada. And if an organization isn't considering this, they maybe aren't aligned with what the rest of the country is really thinking about public health.
Thanks, Sarah. I have another question here from Terry Smith. After working for nearly 20 years in public health and even longer in the healthcare sector, including working through several emergencies, I don't understand how the sector can now be experiencing underfunding and undervaluing from the population or governing bodies. In your view, how can the core competencies for public health be used not just as a guide practice, but to strengthen how public health is positioned and valued within the broader healthcare system?
Yeah, Terry and I feel echo your sentiments and really not understanding, and really unfortunate. Um, I think being able it's hard when you're in public health and you see the value of public health, and so it's hard to replicate. I think about conversations I have with folks outside of the work world, and some of the misconceptions that are had about what public health is, what public health does. Following from the pandemic and from other areas, I think that there's being able to use these competencies to give examples of really truly what public health is and does, because as everyone on this call will know, when public health is working, you don't see it. So being able to use some of this and pull out some of these, not just from the competencies themselves, but some of the glossary of terms, the practice examples that will be coming, using those to really highlight, this is what public health is. I think that can help in some of those conversations.
A question regarding the revised assessment tool. Can you speak to when this will be made available? Can it be as early as May? And then a follow-up question related to the assessment tool. Can you tell us more about it? For example, are any changes planned from the 1.0 tool? And is it possible to have a modified version? Should a regional public health unit wish to adapt it to their priorities?
Mhm. Yes, so happy to provide a little bit more detail on that. So that work is actively underway right now. We have a small working group that's part of that core research team from the funded study we're currently meeting weekly right now to go through some of the aspects of that survey. One of the components of that survey is the self-assessment tool, which will be part of the Canadian Public Health survey that's administered, but that self-assessment tool will also be made available independently. So focus groups have been conducted to get some feedback on that, and we're working to integrate some of the findings from those focus groups into the tool right now. Um, I know that Dr. Belita is actively working on engaging some folks to help with that content validation and pilot testing of the survey. We can look at it as many times as we want to, but we really need people who are working in diverse areas and reflecting diverse roles and disciplines to sort of test it out and make sure that it's working. So that is what's planned over the coming months, and that just does take a bit of time to make sure that we do it right. So I think we can safely say it won't be ready and available in early May, but the plan is for it to be sometime late summer and into early fall for that to be made available once the content validation and those steps and pilot testing has been undertaken. In response, I see there's a follow-up question from Veronique, and I think you're referring to the 1.0 tool that was part of Skills Online from the Public Health Agency. So we do have that on our website as well as a bit of a legacy tool. So there will be some changes from that. To be honest, I haven't looked at that closely in some time. But I think it's probably safe to say that there will be some changes. We actually last summer within our internal teams at the NCCPH, we had just taken that tool and simply inserted new competency statements and did a bit of a test run on that. Not surprisingly, given that the number of statements has almost doubled, it took a lot longer to do, was a lot more cumbersome and more difficult to interpret as an output. So I think there likely will be some more substantive changes that have to be made to that to make it usable and user friendly. But what those changes actually look like, I'm not sure what those will be just yet. To have a modifiable version, I think that's a great idea to have, a general template, but then, some kind of version that could be modifiable for different health units. So I don't know that in that project we've got made decisions on sort of the exact format yet, but I can certainly take that back, and I don't see that being a problem.
Hey, I saw a question here I can quickly answer. Regarding the Slido responses, I can include those, I think, as in the slide deck when we share the slides with everyone. So if you're curious on seeing how everyone responded, they will be included in the slide deck when we share that. Sarah, a question for you from Sarah Pike. Is there work going on to develop competencies for Indigenous health as another project? She said, I attended an in-person engagement session years ago and recall some conversation about this.
Yes, absolutely. And yes, so that work is still ongoing. And we've just received a little bit of additional funding just to support, to be able to support some of that work continuing. So that work is continuing along. We are not leading that work because that's not the role that we should have. That is Indigenous led, but that is still continuing. And so we hope to be able to share some updates on that project soon.
Okay. Are there competencies that address mis and disinformation, building and maintaining trust with public partners on building trust and credibility? What about applications of digital tools and AI and ethical reflection?
Yeah, I think that, specifically in terms of mis and disinformation, I think that again, these are sort of core, this is supposed to be the core competencies that are held by everyone, regardless of discipline. So certainly there's many that contribute to things that we would need to do to address disinformation. I don't believe mis and disinformation is stated explicitly in any of the competencies, but I might be wrong about that. But certainly things like building and maintaining trust, those types of things. I will just add that there is a group led by Dr. Jennifer McWhorter at the University of Guelph who did around the same time as this competency update project was happening. There was a CHR call for research projects around competency development. And so Dr. McWhorter led the development of communication competencies for public health. So again, just the idea that these are the core, and then there might be other stack-ons, whether discipline specific, topic specific. And the National Collaborating Center for Healthy Public Policy hosted a webinar, I believe, 2 weeks ago, where Dr. McWhorter did share those. So possibly we can add into the chat a link to those communication competencies as well, because that likely has a little bit more in that area that maybe isn't part of the core set, but would certainly be really important for that. As well, there was also in that same funding competition a project developing digital public health competencies led by a group at the BC CDC and UBC. I, off the top of my head, don't know if those are totally finished yet, but that is another piece of work that's ongoing and might be a place to look for specific digital tools and AI applications.
I have two questions that are related to the rapid review that the NCCMT had done previously on the core comps. So Emily was asking, since workforce capacity building is not public health specific, as part of that rapid review, was any initial scoping done to explore the utility of competencies and implementation in workplace settings more broadly? And the other question was also looking at how broadly did you look at competencies? Were you pulling from other disciplines?
Great. So within our rapid review, we did focus on application in public health core competencies specifically. Given that public health is a little bit different than other areas, so there's certainly a lot of work on competency-based medical education and in other sectors as well. And so certainly I think there's some lessons that we can learn from that. However, public health is really different in that we are bringing so many disciplines together. And so I think there is some nuance and distinction in how we implement and support adoption for core competencies in a field that's as diverse and complex as public health compared to really focused disciplinary areas. So that was what we chose in our rapid review to sort of help inform the work that we did. It's not to say that there aren't some lessons learned there that we could lean on, but that was sort of our rationale for just focusing on public health.
Okay, I think we have time for maybe a couple more questions. So Angela is asking, knowing we are living and providing public health services on Indigenous land that had teachings and core values of living that encompass many aspects of public health competencies, how do these competencies bring in the teaching of Indigenous ways of being? It looks like there has been consultations with the knowledge keeper. However, why are we consulting and not learning from the ways of being that historically created Canada? Example, bringing forward application of the medicine wheel and 7th-generation teachings.
Yeah, thank you, Angela. Thank you for bringing those really important things forward. So I'll just clarify in terms of our knowledge keeper was a key member of our advisory group. So it did go truthfully beyond just consulting with a knowledge keeper. And that knowledge keeper was part of all of those meetings, started our meetings in a good way. We just brought that group back together again last week. So I think we were really fortunate to be able to learn a lot from her throughout this process. And really a lot of attempts were made at many points to really be keeping these things front of mind throughout and not just in a consultative way at the end. So I think we can speak to that, as well as I mentioned earlier, there are Indigenous specific competencies that are being worked on that, again, I think will really help complement this area. Um, I think it was more than just a simple consultation. As you saw on the timeline, it really kicked off with that Indigenous writing workshop. So we really did try to, address some of the calls to truth and reconciliation, do those things throughout the course of the project so that it wasn't just a simple, you know, consultation. Can you sign off on this? And that's the end. And there's still more work to do, and some of that work is ongoing. And um, we are, I didn't mention this throughout, but we are working to publish a lot of this in the Canadian Journal of Public Health. We have had a couple of the papers already accepted. The Delphi paper may even be published now. It was accepted and it was sort of an in process piece. So there's lots more details within those publications that will be coming out. One of the reasons we feel so strongly about publishing them is to sort of be this record, because as we went to look to the literature, we know so much of this work has been done, but it's not captured anywhere. We're hoping that the process and the learnings from those Indigenous competencies will also be written up to share for others. And we'll certainly be highlighting those in our newsletter and whatnot as they're available.
Okay, and I think we have time for about one more question here. If you have questions that are specific about the content of the core competencies, I do recommend you go to the link Krishan has posted in the chat. It does detail all 64 statements grouped into those 10 categories. So that is a good place to start. And I think our last question we will have is, will there be plans to support northern and rural public health units to engage in equitable competency skill development?
Yeah, thank you for that question. Certainly, we know that there is, we heard resources were a big need, a big barrier to being able to really adopt these competencies, and we know that not every organization is working with the same amount of resources. So that's something that we feel really strongly about, and hoping to that part of our role is, being that sort of broker for sharing some of those pieces and things like the core competency mapping tool, that will be helpful for everyone regardless of the resources available within your specific health unit. Within the project echo that I mentioned, we have specifically engaged some rural and remote public health organizations to be part of those cohorts so that we can see, not only how does this work in large urban public health units in Ontario, but how we really intentionally chose a wide variety of different organization types, different number of FTEs, different populations served, so that we can understand how this works in different settings. And we've also submitted another grant to CHR, to the STEPS grant competition, some of you may have heard of, where again, we were really thinking about centering rural and remote and northern public health, because we know just from an equity perspective that there's often far fewer resources. You're having to do so much more in a very large geographic area with less. So that's definitely something that's top of mind, and through the NCCs, why we make sure that these are all openly available both in English and French. So happy to continue that conversation if there's things that would be particularly helpful for those types of organizations.
Okay, so with that, I am going to just press on. If you do have more questions, please feel free to email them to us. I'll have a slide with our email address there. We always respond. We should get back to you within one business day. So please continue to send questions if you have them, and we'll be happy to address them. I do, however, want to take the time to pose a few questions to all of you while we still have you here. So Krishan is going to launch another poll here. Just to get a sense of how familiar were you all with the core competencies before joining the session today. Get a sense on if you're likely to use our competency mapping tool. And then similar to what we did with the Slido, just getting your thoughts on what other resources might be helpful to you as you adopt the core competencies in practice. So if you didn't get a chance to fill out that Slido, you can provide your thoughts here in the Zoom poll on the screen. And as everybody is continuing to answer those questions, I will just talk for a little bit longer. If you're looking for some next steps on how to get started, check out our nccmt.ca website. As I have mentioned a few times, this webinar slides and the recording will be available. If you haven't already, try our Core Competency Mapping Tool, but definitely start with checking out the Core Competency document, which we have linked both here in the slides and Krishan has provided in the chat. If you are interested in keeping up to date with what the NCCMT is doing, you can subscribe to our newsletter, as well as check out our workshops and webinars page on our website to keep up to date with events that we are hosting in the near future. Follow us on LinkedIn and YouTube. Here we will post whenever we are launching something new. And as we continue to kind of support the uptake of the core competencies in practice, we are looking to gather feedback on how we can improve our core competency mapping tool that Sarah talked about. So we will be launching a short survey to get a little bit of feedback on ways that we can improve this tool and make it more useful for all of you folks. So we will be launching that soon, and we are hoping to share with webinar attendees. So all of you, if you are able to provide your feedback, it would be much appreciated. I also want to address another initiative that we are currently launching. So, do you or your team have a success story involving evidence-informed decision-making in public health? If you do, please submit your story to contribute to the field of EIDM and help build new partnerships and connections. Selected stories will be featured in the NCCMT's EIDM Casebook Issue 4, which will be launching later in the year, as well as contributing to our evaluation regarding the impact of EIDM on public health within Canada. So if you have any case stories about using EIDM in your practice, please submit them to the email address on the screen here. You can visit our website for more details. I think Krishan will provide the link to this call in the chat. And the call for stories will remain open until March 13th, which is next Friday. So you have a little bit of time there. Finally, I just want to say thank you to everyone for joining today's session and for taking the time to participate in the polls and with the Slido. As I've already mentioned, if you have additional questions, please feel free to send them into our email and we will get back to you. I want to thank Sarah for walking us through today's presentation, and hopefully everyone has a nice rest of their week. Here in Ontario, it's nice and warm and sunny, kind of a fall spring, so hopefully everyone gets a chance to enjoy that a bit. And thank you, and good luck with the core competencies.
Thanks, Alana. Thanks, everyone.